Welcome back, everyone. Thank you for joining us for our third year of the Med Safety Exchange webinar series. Thanks to all of you. This is a joint venture by the Institute for Safe Medication Practices Canada, ISMP Canada, and the Canadian Patient Safety Institute, CPSI. Just a reminder that this webinar will be recorded, and the link to the recording will be posted on the Med Safety Exchange website about a week later. We have all the lines muted, and we encourage any questions or comments to be typed to us in the chat box, and we'll read them out loud at the end of the webinar during the discussion period. The purpose of this webinar is to encourage reporting, sharing, and learning of medication incidents and medication safety topics so that we can bridge the silos in healthcare and optimize med safety in all care sites. The following few slides are reminders for many, but I just want to be sure that any new participants are aware of these items. So firstly, every webinar is recorded and posted on the website about a week after the live webinar, and you can click into all of the past webinar dates to access those recordings. Per feedback from last year, we will be sure to include the link to this recording in the thank you email for those who registered for the webinar. And additionally, we will share the availability of the recording using social media like Twitter. Secondly, as of last year, you can access links to materials and resources presented during the webinar that presenters are able to share. This is added at the time that the webinar recording link is added. Not all organizations are able to share, however, so not every presentation will have this link beside the title. But we are grateful to those who can share, as we've had very positive feedback from participants who are able to adapt that information for their internal work. Thirdly, as of last year, the Med Safety Exchange has its own email address, so please send any comments, ideas, or follow-up to medsafetyexchange@ismpcanada.ca. On the Med Safety Exchange website, the big green comments button under each webinar links directly to this email address. And any requests for the PDF version of the slides after the webinar can be sent to this email address for a faster turnaround. Fourthly, the Med Safety Exchange is not accredited because we didn't want to specify certain healthcare professional groups and/or provinces, so we're offering certificates of attendance so that you're able to submit it to your respective colleges or associations and ask about continuing education credits. And these can be done retrospectively because the links are available for all past webinars. Fifthly, to garner as much feedback as possible from you, we've developed several new questions for the post-webinar survey. But since we don't want you to have to answer more than a few at a time, we will be rotating the questions through each webinar. So please ensure that you read each question each time because they won't be the same webinar to webinar. You do have multiple opportunities to respond to the webinar questions, including the poll at the end of the live webinar, and you'll see it on the right-hand panel near the end. And also there's a pop-up web page once you close the webinar window at the end of the webinar, and it looks like this. And there's also an attachment in the thank you email that you'll receive a week after if you registered. Now for today's overview, this webinar, to accommodate the limited availability of one of our presenters, we will be starting with one of the observatory topics, so a quick summary of a med safety related article, and this will be followed by a med incident analysis of an over-sedation event with an opioid, and another topic in med safety segment, so what medication incidents do you investigate? CPSI will then provide us with an update on their current work. At the end, we'll have a discussion period where we read out your comments and we keep the learning going. Anonymity is still a choice for all those involved in the webinar, so I'll only introduce speakers briefly, and they can choose to share as much or as little as they'd like about themselves and/or their practice site. So first up is a summary of a medication safety-related article on discharge medrec.
I had the privilege of working with some pharmacists at Surrey Memorial Hospital just a couple of years ago to do a study on the intervention of where we had pharmacists actually start to do discharge medrec on an acute care of elderly unit. We did this because we were trying to launch Discharge MedRec to meet accreditation requirements across Fraser Health Authority. Primary objective was to examine whether the pharmacists doing this would help decrease the number of discrepancies that these patients had after having the Discharge MedRec service. And we had the pharmacists perform them at Discharge MedRec, as well as do some other discharge activities, including calling the community pharmacy and faxing information to the community pharmacy. We basically followed the complete checklist that was put out by the Institute for Safe Medication Practices Canada. And we had 66 patients in our control group and 306 patients in our intervention group. And we were able to show that the median discrepancies per patient decreased once we had pharmacists doing these discharge activities from 6.5 in the control to 3 in the intervention. Discharge counseling increased, not as much as I would have liked, because 100% would have been wonderful, but it did increase from 22.7% to 65%. I think that we probably missed some when they were discharged on the weekends and the pharmacist wasn't there to do the counseling. And communication with the community pharmacists were similar to the discharge counseling, where increased up to 60% when prior to the intervention, that kind of communication was only happening about 10% of the time. We did have some limitations, which I can discuss a little bit if you are interested. The biggest one is that we were using our pharmacists' monitoring forms to determine what happened with each patient. So any patient that we didn't have a monitoring form for wasn't included. So that gives a little bit of a false picture of our denominator. And but overall, I think there was one other thing that was interesting. We did actually see a change in the readmission rate in favor of the intervention group, but we couldn't explain it, and there would be way too much more work involved to figure out what was influencing that, more than what we could do with the allowable follow-up, since we didn't have the pre-approval to contact patients at home afterwards. So there was an interesting finding, but something yet to be explored for future work. So overall, the clinical pharmacist involvement really did improve the Discharge MedRec planning and documentation. We were able to show some good results, and the service has expanded to other units, and also the model is being copied at other hospitals across Fraser Health to whatever extent is possible with the resources of pharmacists available.
No, that's excellent. Thank you so much. And again, such a rare privilege for us to have one of the authors of the paper present the findings. So thank you so much again for being able to join us today. And for those of you who are curious, this is the hospital-to-home checklist that was used in the study that was just described.
Perfect. Thank you so much, and thanks for having me.
Thank you. So I will like to ask the next speaker to share an incident analysis following an over-sedation event with a post-op opioid treatment.
Thank you for having me. So I will just briefly share about the analysis that we did, and I'm also happy to answer any questions at the end. So essentially this event occurred involving a nonverbal patient with multiple medical needs who had a planned elective surgery to address a progressively worsening condition. And the overview really is that on post-op day 1, a code blue was called for respiratory failure caused by over-sedation that our team felt here was at least potentially preventable, if not very likely preventable. So following a previous elective surgery, which had occurred 8 months prior to this surgery, the patient's recovery was complicated by over-sedation. This is noted by the patient, by her family and caregivers, as well as the medical team. The discharge summary from that surgery included a recommendation to avoid morphine due to an extreme sensitivity and this known over-sedation that had occurred. This was communicated clearly to the MRP at the time, who was the surgeon, but was not necessarily shared throughout all areas of our facility. So prior to this surgery, the patient was seen in the pre-anesthesia clinic for an assessment, and the discharge summary was reviewed, and the recommendation to avoid morphine was acknowledged. At that time, an opioid-sparing post-op management plan was developed and was communicated with the surgeon who was doing that surgery and placed in the patient record. On the day of the operation, the preoperative questionnaire filled out by the patient's caregiver noted that it took days for her to wake up after the prior surgery. And during the lengthy surgery, anesthesia closely titrated her doses of opioids based on their knowledge of this opioid-sparing care plan, but as well as the information provided by the caregiver. Regional anesthesia was attempted, which was a key part of the opioid-sparing plan, but unfortunately the catheter was unable to be successfully placed despite multiple attempts. So there was a bit of a hiccup there that initial plan could not be fully executed. So there was no regional anesthesia during surgery, and the surgical team did recognize that the post-op pain management plan would need to be reassessed. The pain service was consulted and ordered a ketamine infusion, as well as nurse-controlled analgesia, which was a morphine infusion, a background rate plus boluses, and those fell within the typical dosage parameters. So they were on the lower end of the range, but they were not by any means like excessively low or high. They were really just at the very beginning of the typical dosing parameters that we have in our institution. So the ketamine infusion and the morphine background rate were continuously administered, which was as they were prescribed post-operatively, and the nurse-controlled analgesia morphine boluses were administered prior to routine repositioning. So grimacing was noted by the patient after the first repositioning post-operatively, and the nurses at that point felt that that was uncomfortable for the patient and routinely administered it whether or not the patient grimaced. So overnight, so that was sort of, the day of surgery, they were administering that nurse-controlled analgesia, and then overnight the respiratory rate gradually but significantly declined over a 12-hour period. There were occasional desaturations throughout the night, and supplemental oxygen was started for the patient. During multiple visits by multiple care providers, the patient was noted to be asleep and difficult to rouse. The pain service was involved and consulted at that point in time and gradually removed the pain medications. And that was over, this removal of medications was over approximately 4 hours. So they stopped the nurse-controlled analgesia morphine boluses first and then stopped the morphine background rate. When the patient continued to not have a significant response to that, they stopped the ketamine infusion. Due to the continued lack of improvement, Narcan was administered, and initially a bolus dose followed by an infusion, and then while on the infusion, the patient experienced subsequent desaturation, and a second bolus dose was administered at that point in time. Multiple care providers, so including the pain service, the surgical team, the nursing team, the RT were all involved in caring for this patient. And when the RT was adjusting the oxygen and suctioned the patient, they noticed that there was a loss of gag reflex and persistent desaturation despite intervention, and so they called a code blue. At that point, the patient was intubated and transferred to the critical care unit. So the patient was intubated essentially until they, regained their normal respiratory function, was extubated uneventfully, and returned to the inpatient unit 48 hours later. The patient was still discharged home on post-op day 7, as was initially planned for them. So our internal team analyzed the medication incident and determined potential contributing factors, as well as developed strategies to prevent recurrence, which have since been implemented. And we reported the incident to the national database. We did consider this a critical incident at our facility. And we shared the safety story broadly with internal and external staff about this over-sedation event, as we're doing right now. So we felt that the contributing factors, the primary kind of root causes, were that there was inadequate communication of the morphine sensitivity between care teams. So there was an unclear documentation of an allergy versus sensitivity. It had not been entered as an allergy, which is what our allergies field is used as sort of a catch-all where there's a descriptor that you can enter. So for example, and I think I have a slide further along of how that would exactly look on our electronic health record, but nobody thought to enter it as an allergy because the patient did not truly have an IgE-mediated allergy, but just this extreme oversensitivity, and there was some confusion among our internal staff of when the allergy field should be used. And, there was this opioid-sparing care plan, but that was just one piece of an extensive health record that not every single person was aware of or checking prior to administering opioids to this patient. The nurse-controlled analgesia, morphine, was administered by nurses who were unaware of the morphine sensitivity, and it was felt that if this had been in the allergy field, that it would have been visible to every single member of the care team, and even, our pharmacy staff, our pain service staff who maybe were involved in prescribing or dispensing medications for the patient, but were not necessarily having frequent contact with the patient to assess their response to the medication. The other piece was really a lack of recognition and timely response to an evolving clinical deterioration that occurred. So, at what point in time, we really analyzed at what point in time should we have stopped the morphine or not administered further doses, as well as when naloxone was used in that trajectory, as well as, when the actual code blue was called and the transfer to critical care occurred. So the strategies that we implemented here were we updated that electronic health record to improve the documentation of allergies and sensitivities. So we have a comment section as well as a contraindication field, which now is used broadly to capture things like this. So basically, you can see here that what we would do is we would put under still the allergy kind of field morphine and then just put reaction other. And you can also indicate that they have extreme sensitivity and ask all providers to see the opioid-sparing plan so that it's much more clear where that documentation exists and what the plan is for that particular patient. We also modified the order sets for nurse-controlled analgesia to enhance the ability for clinicians to address potential over-sedation early. So we included detailed monitoring parameters, including a consistent sedation score, as well as included assessment of potential side effects of nausea and vomiting, sedation as examples of that, and management guidelines for each of those categories so that there's a clear indication of what the next step should be and who should be notified when those side effects do occur. We also disseminated a practice alert throughout the facility regarding the risk for over-sedation and respiratory depression in all patients receiving opioids. So we described the monitoring parameters so that individuals could recognize over-sedation and respiratory depression earlier on in the trajectory, as well as identifying relevant policies and resources when people are unsure. And compared and contrasted really sleeping versus sedated. So that really came up as a common theme in this particular event, that many people that were involved in this review had a hard time identifying exactly what it means to be sedated versus sleeping, and so we very clearly outlined that in the practice alert and reinforced that with staff throughout the organization. We attempted to also enhance continuity of care for complex surgical patients, such as this one, so changes from baseline could be more readily recognized and addressed. What also came up throughout the course of the review was that it was difficult because the patient was nonverbal and their pain assessment at baseline was more challenging, even using a validated tool such as the FLAC score, which was what was used in this particular case. Then it was still difficult for people to continuously reassess, and there was some discussion that if we had a more detailed handoff between the surgical team and the inpatient care team, as well as that continuity of care of people who really knew the patient, that this may have been picked up sooner. And so we tried to do that as much as possible. So the key learnings really were that communication between teams within the patient circle of care should be thorough and timely, so including pre-op and pre-anesthesia clinics, surgical and inpatient care teams, and that monitoring parameters for patients using opioids should enable timely recognition of and response to over-sedation and respiratory depression, and those should really be responded to in a standard way, obviously as early on in the trajectory as possible. And so I think I will pass it back over to the MedSafety host from the ISMP webinar now, but happy to answer any questions.
Excellent. Thank you so much. And as feedback from previous webinars, we have pulled out a couple key learning points, and our speakers already kind of gone through them a little bit. But Again, this is not exhaustive. There is additional valuable learning throughout the presentation, but we did want to pull out a key point about communication. So the previous surgical team successfully communicated this patient's morphine sensitivity to future practitioners by documenting it in the discharge summary. And then the pre-op team did respond appropriately by creating an opioid-sparing plan. But then, of course, things changed during the operation, and the plan had to be adjusted with the pain service. So they were aware of the sensitivity as well as the need for stronger pain treatment, so they had to find that balance. And the main gap in this case was that the nurses in charge of deciding the dose and frequency of morphine for each bolus were not made aware of the sensitivity. So it was not clearly documented in the patient's chart, nor was it included in the nurse-controlled analgesia directions for the morphine order. So that's an important key point. And the second one that the speaker mentioned as well is the need to recognize opioid toxicity as early as possible, because that enables practitioners to have an appropriate response. So the monitoring parameters are especially important because over-sedation and respiratory depression can be fatal if they go unrecognized. So in addition to the feedback about takeaway points, we also thought we'd include a short exercise on self-reflection, so when you're applying this learning to your own practice. So the first point is about documenting and communicating allergies versus sensitivities, because these nuances need to be specified to optimize safe care. And at ISME Canada, we've actually seen multiple incidents involving unawareness of a known allergy or documentation practices that weren't consistent regarding where one could actually find information about allergies or sensitivities or intolerances. And so the patient experienced harm from unintentional represcribing. And the second point stems from the fact that opioid use is very high in the post-op setting, so it would be illuminating to note how many times naloxone was needed as a rescue agent in your institution. And there is some work being done in the community to reduce the amount of opioids that patients go home with post-op, but perhaps it's useful to look at how much is ordered and administered in the hospital as well. So thank you again to our speaker for sharing this very interesting learning with us. And now moving on to our second speaker, I'd like to invite Dr. Mike Hamilton from ISMB Canada to do a second segment of Topics in Med Safety. What med incidents do you investigate?
Thank you so much, Ambika, and welcome everybody, and welcome to another installment in this somewhat irregular series of medication safety topics. Some of these are theoretical, they're philosophical, but I really do hope that most will be of some practical nature that you can take and use in your own organization. And nothing in this series, or nothing I speak of, necessarily represents the opinion of ISMP Canada or CPSI or anyone in particular, including myself. And nothing in this series is meant to be prescriptive. The intention is to stimulate a bit of exploration and thoughtful reflection. So on your screen is the question, what medication incidents do you investigate? And I think the nature of this is somewhat rhetorical, but this is also a direct question. And I would first off like to thank Donna Forsyth and her team at the NHS Improvement in Britain for doing a lot of the groundwork behind these slides and sort of stimulating great discussion about what investigations do we undertake, and certainly graciously sharing the her information. Her and her group do have an article to be published in July of 2019, and we'll make that available in the resource section when it's out. So maybe we should start with what medications incidents should be investigated. And this is a really complex issue, and it doesn't really have clear criteria, or at least criteria that's easily and readily applicable in every situation. We could certainly investigate everything, but we certainly don't have the resources or time, and we'd end up with investigation fatigue. We can investigate nothing, but then there's no opportunity to learn or to get better. And in a good number of cases, we do understand the contributing factors behind these errors, whether it's a look-alike, sound-alike, or a tenfold overdose. And importantly, we're often aware of effective mitigation strategies, and these mainly are issues in implementation. It may make these difficult and may make these errors reoccur, but that's a topic for another time. So when you're thinking about the criteria to drive investigations, I think it's critical to think of the goal. What are you trying to achieve in this exercise? And I think in general, these fall into 4 classifications. And it's important to note that there's overlap in some very wide gray areas between the classes. There's also perhaps a progression in classes. For example, your incident investigation to prevent a recurrence will indeed certainly cause improvement, and a compliance investigation may indeed provide closure for a family. Probably the easiest to conceptualize are the investigations you do because you need to do them. And really in these you don't necessarily need to decide, the decision is made for you. And these would include things like sudden and unexpected deaths requiring the attention of a coroner or medical examiner. And they also include directives from your leadership or from your ministries of health or some other oversight body. It includes the analysis you do as part of your facility's incident management plan that you need to do for accreditation purposes. And certain provinces as well have things like critical incident programs that demand investigation that reach a severe or a certain level of harm. But again, as I noted in November of last year during a previous webinar, the degree of harm or the degree of severity of harm and thus the resultant need to investigate can vary significantly over which types of harm you take into account. The next 2 classifications, I think, are akin to 2 sides of the same coin, but I think there's enough difference between them to keep them separate. Improvement in quality and safety is probably a very worthwhile goal, and you may have identified a cluster of low harm or no harm incidents, or you may have heard of a vulnerability or incident in another facility and you want to investigate your processes and make them better. And in some way, prevention of recurrence is also very easily to conceptualize, and it's probably the most common underlying outcome we want or we have in mind when we do incident analysis. Again, you've had a cluster of incidents of harm that don't necessarily reach a compliance level, but you have a sense that the incident is important. You want to try to prevent any further similar incidents, or at least do the best you can to minimize any risks. And lastly, closure is important to families, it's important to staff, stakeholders, and really it's a critical part of the safety culture in general. So ideally, the process of analysis results in system change, and that's critically important, but closing the loop with the family and other parties and understanding what happened and communicating that sensitively is a sufficient and valid and vital reason to undertake an investigation. Medication incident investigations in the spheres sort of under which we operate don't include finding causes of death or attributing causes of death or assigning blame. These investigations do occur from time to time, thankfully in general rarely, and are handled under different conditions and circumstances. And I think we all agree that the goal really of any investigation is not the investigation itself, but to identify contributing factors that led to the incident and design interventions that address these factors and reduce the risk of recurrence. Our experience here at ICMP Canada, as well as my own personal experience, and I suspect most of yours, suggests that most of our current incident investigation practices are rule-based. And I think this is widespread around the world. Essentially, an incident happens, it reaches a certain threshold by which we are directed to investigate, and we launch an investigation. And certainly compliance-based programs are rule-based investigations. There's a set of criteria in your incident management plan or as part of a directive that trigger investigations. And in certain jurisdictions, degree of harm levels influence or demand what we investigate. And I think that most departments, organizations, and jurisdictions will be at least aware of never events and demand some sort of response to never event incidents. And certain trigger tools are widely published in widespread use. And one important thing to note that, although in this rule-based regime under which we practice, this is a very reactive way to deal with safety. And we need to wait until something happens before we take steps to fix it. And I really credit the work done by Donna Forsyth and the NHS Improvement Investigations Group for helping illuminate this for a lot of us in medication safety. And the work at the NHS brings up the concept of safety investigations in a management culture context. And this is, best sort of thought of as a quantity over quality. So the number of investigations you do may be more highly prized than the quality of investigations you do. And in management culture, there tends to be a focus on reporting time, on investigation time, milestones, number of recommendations, and costs. We often focus in management culture on the report as the culmination. And we see this, and this is not only in medication safety, where the final report is seen to be as the most important thing and is seen as the end of the incident. But in many ways, this report is only the beginning of the next phase of the same incident, be it analysis and recommendation development, implementation, and monitoring. And this is really not to say that these aspects are not important. They all are. And I'm not saying that management culture is a bad thing. We do need excellent management to keep our organization on track, to keep focus on priorities, provide resources and strategic direction and support. These aspects are essential, but they cannot be the only outcomes. So what if we could add to reactive investigation responses by taking a more proactive approach? Perhaps we could be more strategic, more intelligent, maybe more risk-based with our investigations. Is there a way we could be smarter with our investigations? And how could we move beyond a management culture while still taking what we need from management culture? Maybe we can do fewer but better incident analyses. Is there a way we could be more selective but more strategic and more effective? And in addition to the process measures that we use, can we be more focused on getting it right? What are the true contributing factors? How do we develop truly effective interventions that address these factors and minimize risk? And having a final report is important and terrific, but effective improvement should be the true culmination and not just the report. And this is not to say we leave rule-based investigations behind. There will still be a great need for these, and we still need to analyze them, and we will still get excellent learning and safety improvements from them. But maybe if we take a more proactive approach, we would have less need for these rule-based investigations. So how do we start this? I think a lot of us have some intuitive feeling about where we should start. First, if we want to be more strategic, more risk-based rather than outcome-based, we need to start with the known risks in an organization. And so you look at your data, especially things like good catch data or no harm. Look at other reviews. Talk to your other departments and colleagues. They'll have a sense of where the risks are. And think about the feedback from your safety huddles and surveys. Look at patient concerns and complaints. These are all trying to tell you something. And think about the types of patients your organization serves. Are there particular populations that, for whatever reason, are more vulnerable and may be deserving of further study? And review your previous investigations. Are these recurring problems? Maybe it would benefit from a reinvestigation and a reanalysis. Why do these errors keep recurring? This is, in effect, your safety intelligence. This is what's happening in your institution. And secondly, we need to know what we have to work with. Who are our human resources? What expertise do they have? What time do they have to undertake investigations and analysis? And ask yourself, is this enough? What is our organization and analysis infrastructure? Can we be proactive in the face of all our reactive requirements? And if you don't think you have enough capacity and capability, certainly advocate and push and kick and scream for more. And then based on your safety intelligence and on your resources, pick an area or two of incident risk. Maybe this is an area of a low-level harm incidents that may signify some vulnerability in your systems. Or maybe pick a theme, such as missed doses, and look at your data, ask your clinicians, examine your processes, and spend time developing recommendations. Chances are as well someone has tackled a similar problem, so spend some time reviewing the recommendations of others. And invest time and energy in implementation, and this is really a place where our best plans often falter. So we do know that some organizations already do this. Many of you are already proactively looking for areas in need of improvement, in addition to investigating the incidents that you have to. And we've seen some excellent quality improvement projects based on proactive approach, and we certainly do not dismiss the need for reactive efforts. And we realize that time and resources constrain a lot of what we do in safety, but we also know the value of safety. So think about how you as an organization decide what investigations to pursue, what analyses to perform, what criteria do you use to decide? Is this strictly rule-based? Can you make room for a more strategic approach?
Excellent. Thank you, Mike. Very thought-provoking. So again, some key learning points that we pulled out here at ICP Canada. What we've learned is that the medication safety investigations we undertake are most often for the sake of compliance, triggered by some sort of rule. And these are important and do result in safety improvements, but their nature is that we address the vulnerabilities after the fact. So we do need to wait until something happens. The second point we've also learned is more proactive approaches are recently gaining traction. So this does require an understanding of the local safety milieu, using existing incident data and local safety awareness, and an assessment of what the investigative resources are so that you have a strategic approach to the investigations. And in terms of an exercise for self-reflection, think about previous investigations that your organization has performed. Are they predominantly rule-based? Is there room for a more proactive approach? And how well do you, in a leadership position, know your in-house resources? So do you know what constitutes your safety infrastructure? Do you have enough? Do you need more? And if you're frontline, are you involved in your safety infrastructure? And how can you build your skills and engagement? So again, these questions are a bit of a reflection on what you do in your organization in terms of reactive and proactive types of incident investigations and what capacity you have to undertake analyses. So please feel free to share your answers and comments with us at our email address or in the comment box right now, because we're very eager to see what is happening out there in your practice sites. So we'll now get into the observatory for some quick med safety updates. We did have one at the beginning with the article summary, and we'll now have CPSI give us an update on their med safety initiatives.
Thank you, Ambika, and hello, everybody. Next slide, please. Okay, I'm just going to continue. Starting today, CPSI is hosting a four-part webinar series on the psychological health and safety of healthcare workers. We have some fantastic speakers with specific expertise on how to effectively implement a peer support program in your organization. Next slide, please. The first webinar on confidentiality and legal privilege is currently ongoing right now, but it will be recorded if you wish to access it at a later date. Webinar number 2 on June the 12th will be on the results of a pan-Canadian survey on psychological health and safety of healthcare workers. Webinar 3 will be on June 20th, and it will be a topic of the global environmental scan. And finally, the fourth webinar will be on September 12th, where you will learn about the Canadian best practices. Please visit our website for more information, and we look forward to seeing some of you attend. Thank you. Back to you, Ambika.
Excellent. Thank you, Steve. Psychological health of practitioners is a very important topic, so it's great to see that there's going to be some learning out there. So I do want to thank all of our speakers for the excellent learning shared today, and to all of you for helpful comments and feedbacks. I see a lot of questions coming through, which is excellent. We'll now turn our attention to those questions so that we can have our presenters elaborate. So I do believe that our presenter for the article summary wasn't able to stay to the end of the webinar, but she was providing some written answers as the questions were coming in, so we'll try to do a bit of that as well.
So we'll start off with our presenter about the over-sedation morphine incident. And our first question is sort of related to what you've talked about, and you've outlined some of your approaches to it. Like many of us, we have a very hard time recording and conveying sensitivities that are not truly allergies, such that we usually put information like this in the allergy field. But then that causes all sorts of other issues as well. And related to that is a comment. We recently had a patient with an atypical allergy to an enzyme found in corn. Unfortunately, corn products make up a substantial proportion of fillers, binders, flavors, and other excipients. There's really no good way to capture all of this in a chart, either electronic or on paper. And even if it could be, electronic systems will not necessarily catch this problem if a corn-containing item is prescribed. We still have a ways to go in capturing this problem. We should be working on standards of capturing allergies and sensitivities and how they're recorded, what they trigger, and what to do about them. And for our presenter, do you have any comments on those, how difficult it is to capture sensitivities and allergies?
Yeah, I think we have had, an issue just with documenting even true allergies. That continues to be a struggle, so they're documented in a consistent way so that everyone's aware and that allergies are routinely checked even before medication administration, just at a minimum. And so we have worked very hard to improve that in our facility. I do think we experience the corn enzyme is unique, and we experience a similar challenge at our facility related to the ketogenic diet. So obviously when patients are on, a very, very low or barely any carbohydrate diet, there's many suspensions and other formulations that do contain carbohydrates, and that can be difficult to screen for. So we have adopted the practice of putting that as a contraindication and trying our very best, but when it comes down to it, there are situations like this where a patient-specific plan of care is required, and we have basically a care plan section of the electronic health record where that would be documented if it was something like a corn enzyme that you absolutely can't put in as like an allergy or contraindication. And we try to, use good handover practices and good communication among teams to do our best really to ensure that that doesn't reach the patient, but there are always those unique and very challenging circumstances. For broader patient populations, like the corn enzyme may affect very, very few people that you ever interact with, but for circumstances like the ketogenic diet, we've tried to build in as many electronic alerts as possible so that there actually is a cross-reference between the actual product ingredients and what's being dispensed for the patient. But, it's still not perfect, and certainly people still have to use, their critical thinking and communication skills to try and prevent an event.
And that's an excellent segue into the next question. Often a good handover is time-consuming and has a lot of information, but is really critical to do properly. Do you come up with, or did you develop, or do you find any tools that facilitate the handover of these complex patients?
We have adopted throughout our organization the iPass handover tool, which there are many studies about its IPASS, which is an acronym for each element of the handover, and that's what we've adopted to try and make it consistent for both nursing handover, physician handover, pharmacist handover, so every single person is kind of using the same tool, and that has a written and a verbal component. But I think, there's many tools out there. That's the standardized tool that we've adopted, and we found that it's helpful for interprofessional groups to provide handover and receive handover in the same way, so that when you're talking amongst team members, it's a bit easier to kind of understand where the person's going with the handover, and so that everybody's on the same page. We continue to work on it as one of our safety goals here at our facility. I think, it always needs consistent reinforcement and re-education and ongoing improvement work related to handover, but that's what we've chosen to do.
Excellent. Thank you very much. So I do see some questions for Mike, so I will ask those. So when you talk about being proactive with the error data that you have, it seems you're suggesting we use previous incidents to inform what we investigate. So isn't that still being reactive?
Yes, and I thank you for illustrating the cloudiness between the terms reactive and proactive. I do indeed suggest, and I think the direction is you need to understand what your good catches are, what your low harm level incidents are, and what your vulnerabilities are, whether they're your own or they belong to some other institution and you're concerned. And these are necessarily, I think, based on old incidents. But I think using sort of reactive data in a proactive way is helping you identify patterns of vulnerability or areas of vulnerability or the things that may keep you up at night or the things that haven't happened yet that may be a safety issue before some truly bad outcome occurs. And certainly using older reports or older data, which is reactive, but really not waiting until you you get one of these rule-based triggers happen before you investigate. I think that's the proactive part, is understanding what's happened in the past, but using that data to identify areas that you want to prevent some bad outcome of it.
Excellent. And is there a tool available to give us some idea about how to do proactive med incident analysis?
Yeah, and I think these are being developed. I don't know of one that exists right now or that's been published. Certainly institutions are undertaking their own. I don't know under what rubric or framework they're using. I know that NHS Improvement and Donna Forsyth's team there in the investigations group is working on this and are going to be publishing a number of documents on the NHS Improvement website in July or sometime over the summer. And we'll be certainly eager to look at it, and we'll be quite happy to put the link to it on our website so that we all can learn about this, because this is honestly a relatively new direction. And we're eager to see where it goes and what tools and resources are going to be out there for help.
Excellent, thank you. So we did receive several questions for our researcher at the beginning, and as I mentioned, she wasn't able to stay on the webinar with us, but we will read through some of the questions and answers. So Mike can read the questions, and I'll provide some of the answers that she was able to send to us.
So regarding the pharmacist intervention on the discharge MedRec, question is what types of discrepancies accounted for the 3 discrepancies per patient that remained in the pharmacist intervention group?
So according to the researcher, the type of discrepancy was actually medications started. So the median was actually 0 for medications that were changed and medications that were stopped.
And in this case, what is the physician involvement in discharge MedRec?
So the pharmacist did work closely with interdisciplinary teams, and they reviewed the discharge prescription with the physician, and the physician did sign them so that there would be legal prescriptions for the community pharmacy.
And again, has this been trialed in any outpatient units, such as the emergency department, rather than just inpatient?
So it was not tried in the eMERGE, but pharmacists are heavily involved in BPMH, so best possible medication history, and the admission MedRec in the eMERGE. So this does set the stage for a good discharge MedRec as well. Okay, so I know that there are a couple other questions that did come through, and if we weren't able to answer your questions, we will follow up with an email. I did want to get to the excellent suggestions for topics that we have received throughout the year. So I did select several here for your review, and if you can please reach out to us if you do have something to share related to one or more of these topics, and we will work with you to develop a presentation. So it can be as short as 5 minutes if you like, but we do want to share your experiences and so we can share the learning, because it's important for all of us to try to optimize patient care and reduce the risk of harm. And as always, we do want everyone to be part of the Med Safety Exchange, so whether it's an incident analysis or a Med Safety initiative, please email us to share the learning, even if it's not on the previous list of topics. And please don't forget to fill out the poll that's now available on the right-hand panel. And we'll be asking different questions each time, so please read the survey questions carefully so that we can get the best feedback from you. And again, the link to the recording of this webinar will be available on the Med Safety Exchange website next week, along with any resources provided by the presenters. And registration for the next webinar on Wednesday, July 17th is now open, so you can head over to the website to sign up. Thank you again to all of our speakers for the important analyses and the strategies shared today, and to our participants for joining the discussion and helping to share the learning. I hope you all have a wonderful day, and we will see you in 2 months. Bye for now.